We're super excited to be here with you all. I think I'm going to let our panelists introduce themselves because I've got key questions for them. So why don't we start with, if you can kind of tie it into the landscape of what is food is medicine into your narrative, but we're going to start with Dr. Dexter Shurney.
Thank you. It's great to be here. So I'm the Chief Health Officer for Blue Zones, and Blue Zones has been in existence for 15, 20 years, really transforming communities. And so we call these community transformations. We're in about 100 communities across the United States. And one of the previous speakers talked about the difference in zip codes in terms of longevity, a 10-year span. And we work in those communities as well. And what we try to do is we try to change the environment so that people can actually live longer, better. And we try to do something for everyone, everywhere, is really our mission. And food is a big component of that. So when we do these transformations, we also are changing the food environment for these communities, and we get tremendous health benefits by doing that. We also have an affiliate, Modify Health, and that helps us to span over into the patient provider side. So, we're doing community work, but now we're reaching across the chiasm, so to speak, to really bring in physicians and nutritionists and providers to work with us as well, so that we can build the metrics that are important for the community, as well as for health plans and for physician groups as well. And so in our world, food is medicine is really medicine. And we use it on specific disease states, and we're looking at it more from a lens of benefit design. So medicine is medicine. It's on formularies coming from the drug companies, the manufacturers, and the PBMs, right? But food we see is just as powerful in moving the needle on some of these conditions. Why wouldn't we pay for it in the same way as a generic drug? Because if you can build it into mainstream medicine and not have it something that you do on the side with philanthropy or a grant or whatever, or even 1115, that's fine. But if it's built into the structure, the protocols, the care, clinical protocols that the physicians are using and are rewarded on in terms of HEDIS and those kinds of things, then it's much more sustainable. And you'll see it everywhere. So that's kind of how we look at it, the benefit design.
Amazing, thank you. So now we're going to move to you, Mitchell, from Northwell Health System. Tell us about the hospital and then Food is Health, as you have it there at the system.
Yeah, so for Northwell, food is really considered a part of the prescriptive approach for the patient. Not only from an inpatient but as well as from an outpatient perspective. So for example, on the inpatient side, one of the things that we think is the value of food for a patient who's staying with us is critically important to their overall outcome. And so we are very fortunate to have at every one of our hospitals a Michelin chef. So this is someone who's trained as a chef, and they work collectively with our nutrition team. And together, they create the menus that are meant to really not just, feed the patient, but really holistically bring that patient to the next level in terms of their outcomes. And then we leverage that even on the outpatient side by really partnering with organizations that really are supportive of ensuring that patients or individuals have access to proper food. And so, really taking that holistic approach really gives us an opportunity to really look at not just the 20% of area that's required from a healthcare perspective when you talk about an individual, but also looking at some of more of the holistic components of that individual. And, very similar to what you're saying, there is a prescriptive piece, right? There's that clinical piece that the provider is doing. But when you think about prescriptive, food and its elements around food can also help with that outcome of that person. And so we really try to, sort of integrate the two into one. So ensuring that the patient actually is getting the best clinical care, but also are getting the elements around that clinical care that can actually help them elevate their health.
Amazing, thank you. And David, from a community-based organization perspective, please tell us about community servings, but then also about your newest initiative as well.
Thank you so much, Dorella. It's great to be here. Thanks, everybody. So I lead the sister program to God's Love that serves Massachusetts and Rhode Island. It's called Community Servings. We serve patients at the top of the food as medicine pyramid, meaning we offer both medically tailored meals and medically tailored groceries to people across the 2 states. And of course, you may already be familiar, but it's a very robust nutrition intervention. It includes a nutrition assessment, working directly with your healthcare team, and then a prescription of meals or groceries, and nutrition education and counseling throughout the intervention. The previous panel about the 1115 was really exciting to me, hearing what New York is doing. Massachusetts, in this regard, is 3 or 4 years ahead, whereas New York has been, I think, more focused on ILS or ILOS. Massachusetts has invested a lot in the 1115. So Community Servings has 25 healthcare contracts, but 13 with ACOs through the 1115, and research that's coming out the end of the summer, evaluating the first phase of the waiver. We've just been renewed last year, and made some changes to it. But what's interesting in Massachusetts is that we also have a really robust research and policy program which just launched this week, called the Ample Institute, which kind of brings together the work we've already been doing. But we have 3 large NIH R01 research studies going on the impact of the meals, RCT studies primarily. And so there's great data to bring to our collective policy work.
Thank you, that's great. So I want to tie back to what we heard first from Dexter, and let's tie that to the White House Conference on Hunger, Nutrition, and Health, which was held in September of 2022. There were lots of ideas shared there. You're all talking about innovative models, but they're not across the country. They're not scaled. So can you all talk about, from different perspective, what might be required? And you can touch on any and all points, but I do think it's important to really understand, from the most rural individual, either from a preventative perspective or from the perspective of illness, but then also to an urban individual, like how does healthcare change through the lens of food as medicine? Anyone can answer. Here we go.
I'm happy to go first. One of the things we've learned when we're in different communities is that every community is slightly different. But there is a core, maybe 80% of what you're trying to do is transferable. And so you want to borrow on that best practice, but you want to leave the 20-25% to tweak it to make it what that community really needs. And to Mitchell's point about the quality of the food, that's universal as well. So that's a best practice. I mean, people will stand in line for hours to get to a great restaurant, right? They love the food. And if that food is now healthy, you're gonna get them to engage in that food, eat that food, and now it's making them healthy. So the whole thing about Blue Zones is you wanna make it the easy thing, right? These people so the original Blue Zones research is that people are living to be 100, they don't have chronic diseases and those kinds of things, but they're not waking up every morning, what should I eat? How should I go to the gym? How much time? How many steps am I getting? It's because you've changed the environment that it becomes seamless. And so if the food is good, they're gonna eat it. If it's natural, less processed, those kinds of things. And so you do those kinds of things in the community. And so I really appreciate what the White House did, but we have to really bring it down to the local area and customize it according to what different communities need. And we just have to make it something that people want to engage in.
I also think that it has to also, you have to bring in the payers. And I think one of the things, and one of the programs that we're doing actually right now is with one of our payer partners, Health First, around maternal health and food. And really what you want to do is create the program in such a way that the payer and the provider see the benefit. All right, and so our focus right now are on birthing parents, specifically women who at the current present does not qualify for WIC, but once that baby comes now with their household, they will. So they're really in the gap, right? And so offering some additional funding with another partner, Instacart Health. So we're actually leveraging technology to ensure that birthing parent actually has sustainable food from our Northwell Healthy Food site on Instacart. So we're actually giving that mother, I think it's like $150 per month for them to purchase healthy foods. Your expectation is the birth outcomes are going to be excellent, the mother's outcomes are going to be excellent, and from the payer's perspective, that shows a benefit. For a small investment, what a great outcome. Because really on the payer side, they don't want a NICU visit. They don't want beyond the 3 days for vaginal delivery. And so if you can create programs and you bring in the payers as partners, and in focusing around food to show the benefits of it, I think that also then allows it to be scalable because you have payers all over the country. You have providers all over the country. So if we're partnering together, also it's innovative, right? Because payers and providers tend to disagree when it comes to, payments. But if both are saying the same thing, that this is actually a benefit from our side and a benefit from your side, I think that also creates that opportunity. And so I do think, developing those relationships between the payers and providers is a key way to make it work.
Sounds good. David?
I have sort of a micro and a macro perspective. On a micro perspective, I often say that if the food that we bring you when you're critically and chronically ill looks like my high school cafeteria food, you're not going to eat it because you're already nauseous and depressed. So what Dexter was talking about, I call it beautiful food. It's scratch made, it's cooked the way our grandparents cooked, it's partnering with local farmers and fishermen. Community Servings is doing a case study right now with the Rockefeller Foundation measuring the impact of our local foods purchasing on farmers and fishermen and artisans throughout New England. So I think that the beautiful food part is really important. But I also think when you asked about the White House conference, and I think the question of scaling comes up. And, we run an amazing program in Massachusetts and Rhode Island. God's love is incredible here. There's a network of programs around the country, but our aspiration collectively, I think, is that these kinds of interventions are going to be reimbursed by Medicare and Medicaid. So that might not happen in the next 4 years, but it's close. And we have to be ready. So one program, two quick things that I would highlight. One is the partnership we have with God's Love that is an incubator for new programs around the country. So when you think about what's happening on the coast or in urban areas like New York and Boston, LA, San Francisco, isn't necessarily happening in the middle parts of the country or the South or red states, broadly speaking. So we're sharing our playbook, New York and Boston, to spawn new programs. So in the last 3-4 years, we've spawned new programs in Houston and San Antonio and Tampa and Orlando and Cleveland, et cetera, and really trying to fill out the country because then they become advocates with us in Congress. And this is really a bipartisan issue. As much as there seems to be chaos in DC at the moment, there is hope for a lot of interest. We may have to call it something different or pitch it in a different way, but there is tremendous interest in saving money and lowering healthcare costs, and our collective research has shown, a 16% cost savings net of the cost of the food.
That's great. Yeah, both of you, yes.
The other thing that I think what you just said, David, that had me thinking also is that there's an opportunity for economic vitality here, right? Because you're talking about the local farmers. And as we all know, the local farmers right now are being stretched due to the tariffs and some of the other things. So this actually creates an opportunity. When you think about how the power of food, not from a health perspective, but from an economic vitality perspective, being able to give a new revenue source for local farmers who are consistently struggling. And so I think that's where another opportunity to make it more bipartisan is, because a lot of the states that have these farmers who are using monies that were being, products that were being sent overseas could potentially keep that products here, and working with different organizations such as yours to be able to then feed individuals. And then that revenue for them actually gives them the rationale to continue doing the work they do. So there is an economic vitality component to this as well.
That's great, yeah. Dexter, you're in.
Yeah, I just wanted to say a little bit more about what are you trying to accomplish? And are you using food as medicine, truly as medicine, in inpatient setting, immediately after discharge to decrease readmissions, those kinds of things? Are you using it as a prevention program? Are you using it as food insecurity, a hunger program, those kinds of things, which I think the definition changes. But I also think the benefit and the ROI is different too. Okay. And so when you build these systems, you really have to know what it is you're trying to target, because oftentimes we use everything as food as medicine and we say, oh, it either doesn't perform or it does perform, but we're not all talking about the same kind of program. And so I think it's very important that we are crisp, are precise in what it is we're talking about when we talk about food as medicine.
Got it, thank you. Yes, David?
Can I jump in on that?
You can, yes.
Because the other point I was going to make is, as we're doing research, and the research is stronger and stronger, if the intervention is watered down, if the intervention isn't consistently applied, then you risk having bad research or disappointing results, and that can undermine all of our collective work. So I think one of the biggest exciting things that's happened over the last year is the new accreditation standards created by the Food as Medicine Coalition that looked at what we all have been doing for 35 or 40 years around the country and said, how do we set this as a high bar? It means that a health system like, say, Kaiser, that's working in multiple markets, could purchase from a food as medicine accredited agency meals anywhere in the country and know that they're going to get the same rigor in diets, the same quality of the food, scratch cooking, local purchasing, but also HIPAA standards, data security, et cetera. And I think that's super important, because if we accidentally do research on Jimmy Dean sausage patties, as you might have seen in the news, that's going to blow up the chances for a really robust intervention, and it's not going to be food as medicine if it's mediocre food.
That's great. All of you are touching on different points, but I want to clarify for the audience, right? The Department of Health and Human Services had developed a food as medicine initiative, a clarification. So I want to make sure we're all clear on the categories, and that includes nutrition counseling and education programs, nutrition incentive programs, school lunch programs, produce prescription programs, medically supportive meals and groceries, or medically tailored meals and groceries, and the thing to keep in mind is right now in terms of healthcare, there is no way to categorize those services for a doctor to write the prescription for these specific categories. So one of the things that an organization called the Gravity Project is working on is creating with CMS a billing code for each of these interventions so that it supports what everyone is talking about here on the stage. So here we are talking about where we are now and where do we need to be in the next 5 to 10 years? What does the future hold? So can you talk about what might be possible? What does business working with community-based organizations, health systems, for-profits, pharma, et cetera, what could that look like as change agents for the next 5 to 10 years?
Well, I think we should borrow a page out of the pharmaceutical industry. They do head-to-head trials. And so imagine that you have certain dietary patterns, healthy dietary patterns, and you go head-to-head with some of the pharmaceutical medications out there and show that you can do just as well in terms of the primary outcome for that clinical trial. But they're also, if you think about value-based care, there are additional benefits, because oftentimes the diet pattern that you use for the primary objective, which could be like lowering cholesterol, also decreases the risk for cancer, colon cancer down the road, because it has more fiber in it. It decreases the risk for food insecurity because you're actually feeding somebody. It decreases, you see where I'm going? Yeah. So if you look at that and look at the total value proposition of food and then compare it to a medication that doesn't tackle food insecurity, doesn't oftentimes have a secondary, and by the way, has an adverse drug effect, so that you got to take another drug to treat the symptom that the first drug caused, it's a larger value proposition, so why not include that in the benefit package? So I think that's the future, and so there are more and more people talking about looking at it in that way and doing some sort of head-to-head trials, comparing food to some other things. So I think that's the future, and that's exciting.
That's exciting.
I mean, I think for me, I think the future actually starts with the future in terms of the young ones. I think we have to also spend some time with the children and really engaging with them on food, and food is health. You know, for example, we actually have a program called Wellness on Wheels, where we actually go to different elementary schools within our service area, and we bring the knowledge base of fresh fruits and vegetables to the young kids and actually have them sample them and have them take them home and cook them and really get them to really start to engage in and enjoy eating fresh fruits and vegetables, right? Because one of the things that when you think about from a health perspective is that childhood obesity, right? And how do we kind of bring that statistics down? This is kind of one of the ways that we think that, you know, looking at our children, I mean, we have another program where we actually bring what we call growing towers to different schools, and we work with the science teachers. And they actually are devices where you can actually plant in the room with hydroponic, and they actually grow these leafy vegetables, and then they actually are able to eat those vegetables at lunch together. You know, again, engaging their minds about the importance of healthy eating versus, to your point, Dave, the cafeteria food that we all know, like the old chicken nuggets and things like that. So I think that's where, you know, a future should be, is that we really need to start thinking about the youth and then really making sure we're engaging with them on food is health, food is medicine, and have them, you know, really appreciate the importance of eating healthy.
Yeah, David?
As a social entrepreneur, I really think a lot about how we actually build the field towards the vision that you're describing, and I'm like, yeah. But I often say that, you know, if Blue Cross is thinking about working with an organization like Community Servings, they're doing it because we have boots on the ground. We know what's going on in the neighborhoods. We know what's going on in the household. You know, we know whether somebody's dealing drugs in the hallway outside of where we're delivering, or there's been a shooting on the block recently, and is it safe to make that delivery? And that's really appealing to, you know, the healthcare monolith, that we know something on the ground. But at the same time, they need us to look just like them to be able to work with us and share data with us. And so I think that's where the rub is, you know, for an agency like God's Love or Community Servings, this is our entire business plan. So we're ready to make the investments in technology, et cetera. But if you're talking about the farm in rural Massachusetts that's distributing CSA boxes or food boxes of one sort or another, and you say, you know, is your data system HIPAA compliant? That farm doesn't have, you know, they may have a computer, and it might be a really old computer. So I think how we think about the technology and bringing in kind of the blooming health perspective is how do we do that such that we can not turn away that farm, but still work with them. We did a thing in Massachusetts where if you were you were applying to be part of the 1115, if you were a food program, you had to be able to serve the health system's entire catchment area. But that farm maybe only can do, you know, 3 towns, 1 county, whatever it is. And so as a bigger provider, we said, we'll work with you where we'll take any area you can't serve, but not compete with you where you can serve, so that those small businesses, those farmers, et cetera, are still able to be in the system. But I do think that technology becomes incredibly important, because how do you take the best of a CBO and yet make it look like a Blue or something like that, where we have the same quality of rigor for data?
Thank you all. I'm going to give us a moment to see if there's any questions. If not, I will keep going. Yes.
I have a question. I run a small CBO in Philadelphia, and we get some really great food that are delivered from certified chefs. Yet, our population doesn't want that food. And we have to combat that in, you know, teaching them that this is healthy. But they
Well, how about if I start? I think there's two things there. All of these organizations, and you all can speak further to this, and earlier we were hearing it in one of the earlier panels, equity, right? Or cultural diversity, or honoring cultures in the food that you're providing. But the other thing to kind of consider is it's the diversity of the individuals that you're serving, and then if certain foods aren't eaten in their native country or was never anything that they were exposed to in their home, how does healthcare and then food service providers kind of meet that moment? And I think some of that is in the education we were hearing about earlier, starting with kids and all the way up to parents that may be, dealing with an illness. But, what do others think up here?
Yeah,
Go ahead, Dave. Go.
I was just going to say, one of the things we found interesting, because we're really trying to push more plant forward. And so we will try to serve meals in different venues when people come together and gather. And we learned early that if we said this is a vegetarian chili, nobody wanted it. But if we just called it, Marcella's, chili or something, people would eat it, and then later we would give them the recipe, and they said, "Man, that was really good." So yeah, I'll take some more. But some of that is also, but they have to experience that it can actually be good too. Otherwise, they'll think they're eating something, they'll get it, they like it, and now they've experienced it and they want more of it. So I don't know.
In the medically tailored meals programs all started in the HIV community, and there was a time in the early part of the history where there were programs trying to from chefs that wanted to treat the person with respect, and so they were bringing them salmon with the dill beurre blanc sauce, thinking that was going to be meaningful and respectful, and it was the opposite. It's like if you didn't grow up with salmon, if you don't you can't pronounce dill beurre blanc, what does it mean? So I think it's always about a relationship with the person and respecting, to Dorea's point, respecting their cultural norms, and yet also bringing them along, as you said, to a healthier diet. So if they see, if they're Ethiopian and they see in the course of a week, they might see something that's got the flavorings of an Ethiopian meal, you may hook them. Where we see obstacles is like we do a lot with ancient grains and quinoa and things like that, and people will turn up their nose at it, but after they've had it for a while, they'll start to eat it, and they'll say, "Oh my God, I had no idea, I really like this," and you're just broadening their palate, but you can't just do that from a place of power, like you will eat what I tell you to eat.
And I also think, inviting other chefs from the different communities could also potentially help, in terms of, and I don't know the setup, but, what we've learned, and we worked with our dietitians in creating what we call culturally sensitive plates, right? So we have a Caribbean plate for a diabetic, bringing in, the foods that they tend to want to eat, but showing how that food can be created using the nutritional values that they need to be a diabetic. So one of the things is potentially bringing in some additional chefs from those different cultures to kind of work into your network so that you have a more broader network. And then at some time, I always love the word, that fusion word, right? Because you can begin to integrate different cultural foods into a different taste that then they were like, "Hey, I've never had this before, but it is great." And because it has elements of their cultural background. So I would also say that's an opportunity where you can bring in multiple chefs from different cultures and begin to try to create some fusions. And then you elevate the sounding of the food because you're now using the word fusion versus just, a direct taste.
Yeah, this was great, everyone, an amazing panel. I hope all of you will join me in thanking everyone for joining with us today. Thank you, sir.